co-moderator, Dr. Jeewan, TITIYAL. Comparative evaluation and morphological and visual outcomes using two laser capsulotomy devices.
Thank you so much. Good afternoon, friends. This is a study which we're going to compare two automated devices to do a capsulotomy. No financial disclosure from our side. You all know that from manual capsulotomy to we have shifted to continuous curvilinear capsulorhexis, mainly because of FICO became so popular. Then now we have a laser capsulotomies, which can be a femtosecond laser, or it can be JEPTO, which is with a nitron ring, or you can have capsule laser with the recent application we have now also. This is our initial publication where we compared the femtosecond laser cataract surgery from the conventional surgery, where we could assess the capsulotomies and capsulorhexis and two. We realized that with the femtosecond laser, you have a better sizing as compared to a manual capsulorhexis. It was significancy of 0.001. In terms of mean circulatory index, that means the circularity of capsulotomy or capsulorhexis were far better with the femtosecond laser device. That also was significant. And this proved that in wide cataracts, if you use femtosecond laser, it gave us a better centration and better circularity and better sizing of a capsule. And this is what we are going to compare with the capsule laser. I know that we have a subsequent speaker from Pune, Dr. Kelkar is going to talk about further also. So selective laser capsulotomy is, needs a very nice staining of anterior capsule with trypan blue dye. It absorbs the orange wavelength dye, which will be applicable to the stained capsule and makes the capsulotomy in a less than 0.03 seconds. Because the type 4 collagen, which gets apoptosis collagen change. This is a study where I looked into, to compare the morphological features of femtosecond versus the selective laser capsulotomy in these patients in a prospective comparative study design done in RP Center, AIIMS, New Delhi. 30 eyes, 15 each group were taken. The primary outcome for these cases are the shape and morphology of capsulotomy. The secondary outcome was intraoperative complications associated and visual acuity at 1 month after surgery also. This is a small video on how we do surgery, and this after we do a good staining of the capsule, you have to displace with a proper viscoelastic. Normally we use sodium hyaluronate 1% in these cases. Proper focusing will give you a nice application laser. Like this is the good focusing is done. I think focusing one important criteria in these cases after fixation of globe and the entire laser is done, there's a retraction of a capsule because of coagulation happening in these cases. And the surgery is very, very simple. So this is the target size. We are planning for 5 millimeter target capsulotomy. In the results, we achieved in a post-op period, which was 4.08 millimeter capsulotomy. There's a slight shrinkage of capsular size happening after capsule laser. The second case, 5.3 target, and we achieved 4.48 millimeter capsulotomies. Therefore, we need to target slightly larger size of capsulotomy in these patients so to achieve good coverage of peripheral part of IOL in these cases also. In terms of looking into intended capsular opening size, there was around 0.6 diopter change from the effective, which we planned. The predictability was slightly less compared to a 0.1 in femtosecond laser. In the mean circularity index wise, it was almost equal in the two groups. The anterior capsulotomy extension was observed in 2 cases of femtosecond laser, none in SLC cases. There were complete capsulotomies in these cases. The visual outcomes were comparable in 2 groups of cases. So these are a subsequent outcome in these cases. There was a little difference between a femtosecond laser application as well as in wide cataract cases with capsule laser. In femtosecond laser, you have a sudden egress of a fluid, while in a wide cataract application, there is a slow egress of fluid happens. You can see after laser application, the fluid release is quite slow, and that prevents the extension happening in these cases. This is the advantage we have seen with the capsule laser device as such in these cases. To conclude, Laser-assisted capsulotomies are a well-centered, circular, and continuous in all both the femtosecond and capsule laser. Effectivity-wise, femtosecond laser seems to give a better predictable size, while the complication related to extension is very little with SLC. To summarize, as such, circularity index will be better, continuous is better because tissue bridges are lesser with SLC. And strength-wise, this is a study by Daya et al. They found that it is 1.5 times stronger than the CCC. And size-wise, you have to little titrate to get a better size in these cases. So this is a welcome addition to your cataract surgery as such, easy, less time-consuming, less expensive, and cost-effective also. Thank you.
Any questions from the audience?
I think this is a new thing, people will look for that. This is a microscope attached system. You don't require a large, big box of femtosecond laser, which is so costly and difficult to maintain also. If you have this, the most important part, that is a capsular opening, can be created easily, effectively, and better shaped also. So people might look for that. Yes?
Yes, ma'am.
Just now, it is, in India, it is, I think, taken care by My Healthscape people. They are providing this. As more people will go for this, the cost of this machine will also come down, because this is one important. Once you acquire the machine, there's not much of additional cost. You don't require PI in each case in these group of cases. That's also less costly for all of us and patients. It's in a microscope during surgery only. Yeah, it's attached to a microscope. Yes. Yes. Any microscope it can fit in. Yeah. Yeah. Like you have for your Bitoretina biome fitting type of thing. I'm not sure. I'm not purchased yet. We had a machine as a demo for 1 year or so, and maybe Jack can say later. Because they have this machine, Kelker group have a long time, Complication, yes. If your focus is not accurate, you can have a skip areas. And if you by mistake stain the endothelium, because the dye is absorbed by these staining. So you should avoid staining coming to endothelium. Otherwise, it will form the ring in the endothelium also. So that is avoided. So staining has to be just anterior capsule. Recently, we have shifted to a painting of a capsule under the viscoelastic. So that gives a very smooth staining, and the staining should be there for longer time. It should be a thick staining. Yes, 100%. Viscoelastic is just to that's normal, like to flatten the anterior capsule.
I think you have to differentiate this with the femto, because in this system, the laser fires from the top and uses the stain and the energy of that cuts. In a femtosecond laser, the laser will fire bubbles from behind, from inside the lens capsule going outward. So this one is going down. The femtosecond laser is from inside the lens going up. So that's why when they fire, the milky, if it's a milky cataract, it doesn't obstruct the vision. Whereas when we use a femto, the bubbles percolate and the milky substance goes up. So that the application is different. This one is from the top down. The femto is from inside out.
Yes.
So that's the difference. That's why this one, that's why in the femto, sometimes when you fire that in a milky capsule like Harvey, sometimes boom, there's an explosion, because if it's a phacoemorphic lens or something with high pressure, you sometimes can get an extension of the cut.
And also you have a high chance of skip areas with the femtosecond laser, because your the configuration of capsule changes, or some areas will be blocked by this milky fluid.
Yeah.
It takes slightly more time than the capsule laser. Capsule laser is very fast. With a blink of thing, it happens. And it's just a coagulation. It's sort of an argon laser. So it's very strong. It is supposed to be a 1.5 times stronger than the routine CCC, which is stronger than the femtosecond thing. And because of this burning, it's like a coagulation. the edges are little thicker, and it's very strong rigid. So in that way, that prevents the extension. Also in a post-op period also, we hope that it will prevent the cellular migration towards the IOL surface also. Yeah. Okay, thank you.
Okay, thank you very